Politics and Healthcare, a look at the COVID-19 pandemic. Healthcare in America is political. Its quality, availability, and access are all determined by forces dictated by political economy. Despite being the wealthiest nation on earth, America's citizens are not the healthiest in the world, and its healthcare system is not the most efficient. The United States leads the world in healthcare expenditure, yet its life expectancy of 78.6 years is a full 2 years less than the OECD Cooperation Organization for Economic and Cooperation and Development average of 80.7 years, and a full 5 years less than the leader, Switzerland, at 83.6 years. Furthermore, the life expectancy of people of color in America, particularly African Americans, is 75.3 years, and its males is 69.1 years, a full 6 years less than the national average, and it is over 14 years less than the world leader. America has the highest suicide rate in the world, the highest rate of chronic illness, obesity, and hospital stays for preventable diseases in the world. Why? There are essentially three main reasons: materialism, capitalism, and racism. Materialism and the idea that there is only matter in the universe and not some overarching, energetic, wave-like spiritual dimension animating and underlining the entire universe lends toward a mechanistic worldview. This mechanistic worldview limits the parameters in which health and healthcare can be assessed, and therefore limits the vision of what is possible. Vandana Shiva in Oneness versus the 1% writes, "The mechanistic worldview was crafted to serve industrial capitalism, which elevated an inadequate, reductionist, mechanistic paradigm to the level of science, while scientific thought, based on the awareness of a living earth, was politically relegated to non-science, even anti-science. The mechanistic worldview then leads to a capitalist perspective, which has strayed from its altruistic ramifications as outlined by Adam Smith in The Wealth of Nations. It embraced a distorted Darwinian idea of survival of the fittest in nature, used to justify wanton competition, search for unlimited growth, and a sole focus on profit. And racism, coupled with the white supremacist history of American medicine shape-shifting to the whims of political forces, has affected the outcomes and levels of trust. Both materialism and capitalism shift the focus of healthcare from the patient or citizen's health and well-being to the maximization of material gain, profit. Racism, sexism, and a lack of cultural competency all minimize the effectiveness, access, and affordability. This profit motive skews the objectives of the healthcare system. Rather than solely focusing on patient care and health, it demands that the focus remains on minimizing costs, limiting expensive but often necessary procedures, and shortening hospital stays. These factors, plus the overarching environmental crisis and climate change, has tipped the current scales of world health to the side of uncertainty, panic, and a world pandemic of an infectious disease. The COVID-19 pandemic. Pulitzer Prize-winning journalist Laurie Garrett wrote The Coming Plague in 1994. In it, she chronicled how impure drinking water, overuse of antibiotics, war, and impending environmental crises, including climate change and deforestation, led us to a vulnerability to viral pandemics and future catastrophes. The pandemic of COVID-19 is just the latest of killer viruses that have jumped across mammalian species to infect humans. It is not the first, and unfortunately will not be the last. There was the H1N1 in 1918, that killed 50 to 100 million people. There was the flu of 1958 and then the Hong Kong flu of 1968 as well, both killing over 100,000 people in the United States. There has been the human immunosuppressive virus, HIV, that causes AIDS, which has killed over 30 million people since its emergence in the early 80s. The Ebola virus, which is one of the most lethal viruses in the world, erupts periodically in Africa and has killed over 30,000 people, leaving thousands of orphaned children. In addition to AIDS and Ebola, there have been epidemics of renewed H1N1, Middle Eastern Respiratory Syndrome, or MERS, as well as SARS, a precursor and cousin to our present crisis, SARS-CoV-2 or COVID-19. What is COVID-19 and how did it originate? COVID-19 is short for coronavirus that began in 2019. While that is the disease name, the name of the virus is SARS-CoV-2. SARS is severe acute respiratory syndrome. That means it is very serious, comes on suddenly, affects primarily the lungs, but is diffuse and can have widespread effects within the body. It is named a coronavirus because of its crown-like shape and appearance. It is named 2 because a variant of it first appeared in China in 2002. What are some of the common denominators to all of these epidemics and pandemics? They are bats, deforestation, industrialization, globalization, and profit motive. What is the relationship of SARS-CoV-2 or COVID-19 to bats? Bats, in this case, are the vectors, incubators, and carriers of this disease. Why? Bats are the carriers of thousands of viruses. In fact, there are millions of viruses carried by mammals that could potentially infect humankind. And bats are the only mammals that fly, enhancing their ability to transmit disease. Why bats and why now at this particular time? The answer to this question is complex, but involves several overlapping and overarching phenomena, namely the deforestation as a result of rapid industrialization of China and much of Africa and the Middle East, and the multi-layered environmental disruption it causes. And then there is climate change. What has caused the present pandemic, and what are its political ramifications? There are several theories about the cause and origination of the COVID-19 pandemic. The most plausible theory involves rapid industrialization, in this case, China. While China has charted a socialist path in theory, in reality, it is a state-run capitalist society. This means that while certain favored individuals profit and get rich, the bulk of its profits go to the state. In its efforts to catch up with the West, particularly the United States, China embarked on a rapid path to industrialization, including its agriculture. This new focus has driven many small farmers out of business. Formerly, an individual farmer could eke out a living by growing enough crops for his family and for the market. Due to the pressures of competing with large-scale agriculture and deforestation, small-scale farmers resort to raising pangolins and other exotic animals, relatively rare mammals to sell at markets. At the same time, the same deforestation and environmental disruption causes stress within the local bat population. When bats are stressed, they do not create enough internal heat to kill new and old viruses incubating within them. These active viruses, particularly the new ones, are then shed in bat feces. Pangolins, who were formerly free to roam the countryside, were then marketed more frequently at local markets and became exposed to the bat feces because they too are considered a delicacy and are in close proximity in large open-air markets. This creates a perfect storm for human transmission because humans eat both the bats and the pangolins. While this is just one probable scenario, Its plausibility is high because in every case of 21st century viral outbreak, some sort of animal to human transfer has occurred. So, what exactly is SARS-CoV-2 and COVID-19? Like Laura Garrett explains, it is just the latest of many potentially killer viruses that are nearly certain to plague humankind for at least the next 50 years, maybe longer. There are over 1.5 million viruses that could potentially infect humans. This means that the chances of human transmission is highly probable. In December of 2019, in the city of Wuhan, China, a bustling metropolis of over 11 million people, an outbreak of a yet unidentified virus began to cause severe lung symptoms requiring, in some cases, hospitalization. Within days, the unidentified virus spread and claimed its first victims. At this point, the world community, including the World Health Organization, were not overly alarmed. Within weeks, though, the unknown virus, due to readily available air travel and globalization, began to spread to Southeast Asia, Europe, and America. Due to China's reticence to fully disclose the exact nature of the outbreak and fear of economic loss, precious time was lost initially to properly respond to the emerging crisis. Additionally, Western societies, more worried about their economic fortunes, failed to initially respond with a sense of urgency and necessary agency to ward off widespread infection. The US, in particular, under the anti science administration of Donald Trump, ignored the well publicized outbreak, choosing instead to bask in its own hubris of denial. So, what is COVID 19? What are its symptoms? COVID 19 is a syndrome that first attacks the respiratory syndrome, the lungs, and eventually, in at least 15 to 20%, affects the cardiovascular system. Its most predominant symptoms are fever, dry cough, exhaustion, expectoration of mucus, shortness of breath, sore throat, headaches, muscle aches, chills, vomiting, stuffy nose. It must be added that now sometimes people have long term symptoms of cognitive difficulties. A few, 5 to 8% have psychotic breaks. Some have loss of taste and smell, and some have hearing and vision problems. Spread through coughing, sneezing, and physical contact, and possessing the ability to be spread by asymptomatic individuals, COVID 19 has proven to be one of the most effective and smartest viruses to have attacked humankind. It is effective because it is easily spread, hard to detect, and can coexist without causing symptoms. This means that carriers of the virus often do not know they are carrying and spreading the disease. It is smart because, unlike Ebola, and until recently AIDS, it does not seek to kill all of its victims. If it did, it would not live long enough to spread effectively. COVID 19 has reached a perfect balance whereby it spreads itself, yet preserves enough hosts such that it can remain active and spread. The goal of a virus is to live and replicate, and in this sense, COVID 19 is ingenious. The key to understanding the virus is understanding the specific cells that are targeted and why. The specific cells that are targeted are cells within the endothelial tissues that line all of the blood vessels and organs of the body. Unlike H1N1, which limited itself strictly to lung tissue, COVID 19 targets cells that are literally all over the body. It focuses on the ACE or ACE receptor in the endothelial tissues that control clotting and the regulation of inflammatory processes. The end result for many is a heart attack, stroke, brain aneurysm, pneumonia, or pulmonary embolism as a cause of death. At least 20% of those who contract COVID 19 develop symptoms, and of that, at least 15% require hospitalization. Nearly 2% of all cases are fatal. This is why clotting and an excessive inflammatory response are the long term dangers of COVID. It starts off as a respiratory illness whose morbidity and mortality are due to dire cardiovascular circumstances. At present, there are over close to 27 million cases of COVID 19 in the United States, with nearly 456,000 deaths. Individuals with pre existing cardiovascular disease, like hypertension and diabetes, are more susceptible because their endothelial tissues are already impacted and damaged. Who gets COVID 19 and why? Who dies? The individuals most likely to contract COVID 19 are those who are directly exposed to the aerosol droplets of an infected person for 15 or more consecutive minutes. Repeated exposure under indoor conditions enhances one's vulnerability and chances of contracting it. That means those who are out and about and stand a greater chance. That includes workers deemed essential. Essential in this case really means necessary. The bulk of workers classified as essential are African American, Latino, Filipino, immigrant, poor, and in some areas, Indian and Alaska Native individuals. These groups also have the highest percentages of comorbidities in cardiovascular disease and diabetes as well. These two conditions, proximity and exposure to the disease and comorbidities, account in part for the high numbers of fatalities from COVID 19 among all of the aforementioned groups. But what accounts for those groups being the predominant members of the essential class of workers who also happen to be on the bottom of the social hierarchy? And why do those same groups have the highest incidence of chronic disease, that is, comorbidities? According to the National Institute of Health, American Indians, Latinos, and Alaska Natives have a 3.9 times chance of contracting COVID versus a white American. African Americans have a 3.6 times chance of contracting it. African Americans die twice as often from COVID, while the rate for Indians and Alaska Native is 1.5 times and greater chance, and Latinos 1.3. Why? The reasons are numerous, but all are due to generations of economic inequity, racism, and a white supremacist foundation to the entire fabric of the American government. Specifically, it is due to a lack of resources, distrust of the medical establishment, and a lack of physicians of color. With regards to resources, several factors are highlighted. People of color live in communities that have smaller hospitals, that receive less funding, and therefore have less available PPE and testing. There is inadequate early testing. People have to travel further to get tested. People are more apt to live in testing deserts in rural communities. Severe variations in hospital resources leads to a poor in communities of color dying 3 times more than affluent hospitals. The issue of distrust of medical system means that even if vaccines to COVID-19 are available, many people of color, African Americans in particular, may not take it. In a survey, while over 91% of Asians, 74% of white and Latinos said that they would take the vaccine, only 54% of African Americans said they would. Why? The reasons are many, but all lie within the historical experiences of having been enslaved and viewed simply as chattel, property. For over 200 years, the medical establishment was complicit with the white supremacist ideology of attempting to promote the idea of racial and intellectual inferiority of Africans as compared to whites. Additionally, African Americans are aware of the Tuskegee experiment, where young men were intentionally infected with syphilis and denied treatment from 1932 to 72 to study the long-term effects of tertiary syphilis. Similar studies were done around yellow fever as well in 1955. Even today, 40% of white medical students and 25% of resident physicians believe African Americans have thicker layers of epidermis or skin and are therefore more impervious to pain. America also has a history of its early white settlers intentionally giving blankets infected with smallpox to Indians. Spanish speaking immigrants and citizens often distrust the medical system as well because the documentation of receiving health services are often used against them in immigration hearings, and people are uncertain as to how health information might be used. This cumulative level of distrust then translates into less services, less care, less prevention, and less treatment. Furthermore, the lack of insurance, physicians of color, neighborhood hospitals, paid sick leave all add up to communities of color and the poor receiving less health care. With regard to COVID 19, communities of color, the rural poor, and undocumented immigrants are particularly vulnerable when it comes to the treatment and protocols of sheltering in place. Taking time off work and quarantining in one's home are difficult to carry out. Those with means and privilege have homes large enough to self isolate with paid sick leave, savings, insurance, and a history of health care such that their degree of chronic disease is lower and, if apparent, medically managed. They have less comorbidity and more money and more time before their family is plunged into a financial crisis. This reality is politically and economically determined and not controlled by personal agency or happenstance. It is structural, built into the American system. Those who make less have less, and those that have less do not work less. In fact, people of color and the poor work more. What all of this means is that despite the United States being the richest nation on earth, with the most advanced technology, most skilled and well trained physicians, and the most up to date facilities, it is unable to fairly and equally distribute and administer health care to its citizens because the system that controls it inherently needs a hierarchy that demands someone to be on the bottom. It is part and parcel of capitalism's functioning. All of this has been brought into stark relief as a result of COVID 19. It has brought to light the inequities of not only America's healthcare system and its inequities and contradictions, but the lack of national concern around thousands of Indians, Latinos, African Americans, Filipinos, and poor people dying of COVID 19. In many ways, it is a form of neglect bordering on genocide. What can be done? With respect to COVID 19 in particular, it is recommended that test locations should be strategically located in all communities. And we must increase equity as regards treatment, foster more culturally competent care, and appropriate translation services, increase community outreach and engagement, prioritize preventive care, close persistent gaps in racial disparities, and increase vaccine availability. Leah Zamore and Ben Phillips, in a paper titled COVID 19 and Public Support for Radical Politics, go even further. They advocate a redistribution of wealth, policies geared towards social transformation, lessening corporate power and increasing the power of workers and consumers, increased taxes on the wealthy, increased direct action by grassroots activists to maintain pressure on politicians for bolder policies. What does the future portend? In the immediate future, the question of which paradigm will emerge as the dominant ideology and philosophy will come to a head. Do we continue to adhere to a materialistic and mechanistic orientation, or do we embrace a holistic vision more in tune with our 300,000 years of indigenous and shamanistic systems of healing? While it is not possible or feasible to go back in time or mimic indigenous ceremonies without being a member of a specific tribe or group, it is possible to apply modern theories around health that are compatible to indigenous thought and practice. One such theory or paradigm is suggested by the work of Dr. Irving Dardick. In his book, The Nature of Nature, Dardick advances ideas compatible to modern day quantum physics. Quantum physics posits that at the most fundamental level, subatomically, the smallest particles act like both matter and wave. They go back and forth from a material particle to a wave of just energy. Dardick wrote that the entire universe consists of waves of varying frequencies, and the human body is dependent on these waves, externally and internally. These waves, connected to our circadian rhythm, are intricately tied to our cardiovascular system and the beat of the heart. Based on this, he devised a method of exercise that alternated running with stillness to train both the active and passive phases of the heart. This, in turn, would create a wave within the body that stores it to its physiological balance or homeostasis. Similar to Dardick are the ideas of Dr. William O. Becker in The Body Electric. An orthopedic surgeon, Becker found that extremely low electromagnetic fields applied to fractures improved healing. From this, he theorized that the body has subtle energy fields that could be utilized in healing. Both the work of Dardick and Becker, in addition to many others, build upon thousands of years of indigenous healing systems that all believe that the body has a vital force. This vital force, known by many names, chi, prana, huna, innate intelligence, nam, orgone, is said to be our connection to the energy of the universe. The emergent technologies of nanotechnology, robotics, and artificial intelligence potentially could revolutionize American medicine, as they will allow physicians to work at the cellular level with precision. Yet, as long as the dominant paradigm is materialistic and mechanistic, the focus of the medicine will be on magic bullets, focusing on allopathic remedies that heal from the outside. Traditional shamanistic and energetic systems focus on healing from within through harmonizing with the environment and the cosmos. So, the question, whether it is COVID-19 crisis of 2020 or 2021, or similar crises laying ahead, is how can we demand full equity in the present day healthcare system while we simultaneously envision a system that combines our indigenous ideas of universal unity with the possibilities of the new technology and a political system of egalitarianism and social justice for all? These are my references. There are several other scientific articles that I used. If someone wants those, they can email me and get that information. Thank you.